We are talking about sustainability strategies to keep the doors open. My name is Patsy Nelson. I'm one of the presenters. I represent the New Mexico Alliance for School-Based Healthcare, which is our state alliance here in New Mexico. I also was a school-based health center coordinator at one time. I was a school nurse before that, and so have been in the field for a long time. And now I'm retired, and I just like volunteering. So that's what I do, and we're delighted to have you here today. Thank you for coming to New Mexico.
Great. Good morning. My name's Carol Pierce, also one of the co-presenters, and I also have no relationships to disclose. I'm a public health nurse consultant here in New Mexico with about 30 years in healthcare experience, even though I'm only 25 years old. Just kidding. And I've had I always like to describe my career in decades. My first decade was really working in the acute care side of healthcare, and another decade as the public health district director for the state of New Mexico for one of our regions. And my third decade has really been being a public health nurse consultant to a lot of our partners in really looking at how can we have school-based health centers be a key part of the healthcare delivery system. And thank you for being here. We're delighted that you're here.
Okay, and part 3. I'm Yolanda Cordova, and I also have no relationships to disclose, so I just want you all to know that. I'm with the Department of Health, and I'm actually the director for the Office of School and Adolescent Health. And our office is responsible for overseeing school-based health centers across the state, as well as school nursing, youth suicide prevention, and youth engagement projects. So we're kind of set up a little bit different probably from some other offices. We have quite a bit. It's a great opportunity because it gives us the chance to really broadly coordinate adolescent health activities going through the communities and also through schools. And so my background is, before coming to this position, I actually have a master's in social work, so I worked in the field of children's mental health for a long time. I was actually part of child welfare for a long time, and then I also did a lot of work with developmental disabilities and had one stint where I worked as a director for disabled student services at the University of Texas at El Paso. Okay, so I think it looks like we had some folks trickle in, so that's a good thing. And what I need to do is describe what our objectives are going to be for the session. When you leave here, we hope that you'll be able to describe the benefits of partnerships to improve reimbursement for services provided by SBHCs, patient health outcomes, and quality of care in school-based health centers through piloting new concepts within healthcare reform. You'll be able to identify some key concepts, key components of a patient registry for health improvement and data collection, and discuss changes that must be made for SBHCs to become an interface with patient-centered medical homes. I think at this point I want to sort of get a feel for who's in the room with us today. That kind of helps us to, as I'm thinking about these objectives or as we're working through these objectives, we kind of have an idea of who's with us. So if you're a school-based health center coordinator or working as part of a staff in a school-based health center, will you please raise your hand? Okay, so that looks like a large majority. Okay. And then if you're a partner, you're working in either the healthcare industry and you're an administrator of some sort that's helping to support school-based health centers. How many are you, those members? Yay, we've got some of those. And then how about just other community members with community-based organizations or nonprofit organizations that are also involved with school-based health centers? Okay, well, if I didn't get everybody, you could do a shout out for me. That'd be great. I don't know, I didn't even ask if we had parents in the room. Sometimes I feel like we go to these conventions and I hope that we have family members also, community members as part of this, because you're part of the picture of sustainability. We really need our community members that make up our youth and also our family members to help support sustainability. I want to mention also that the session is being videotaped, or not videotaped, it's actually live streamed. So you notice all these microphones, we're all mic'd up, we've got lights on us and so on and so forth. So that means when it's not kind of the same session as you've been in. So if you have a question, what we're going to do is you have to actually walk up to the microphone because it's going to have to be recorded into the session. And it's actually keeping us all anchored so we can't walk, so we got to stand right here by the microphone because we got to make sure that the folks that are streaming in watching this session can actually hear us. So we'll take questions, but we're going to ask you to come to the mic. All right. Let's see. So here we go. This is the title of our session. We're talking about the strategies to keep the doors open in New Mexico. We've done some amazing work in this area. We have, as you can see, the folks that are here even presenting with us, we have a really strong partnership in New Mexico. We actually have a group that's called our SBHC Partners. We meet at least every other month, and we actually have a strategic plan, and we work towards talking about sustainability for school-based health centers, and always on that are the three key components that we're going to be talking about today. So what we think about when we think of the domains of school-based health center sustainability are those three items up there. Partnerships is a really important key to this, as you can see with us being up here with the New Mexico Alliance, with our partnerships with the university, with schools and communities, et cetera. We need these folks to help us talk about these pieces. So partnerships is one of the key components to sustainability. The second is finance, and obviously we've got to have some dollars. We've got to figure out where that's coming from and how that's all put together. And then finally, our last part of it is practice. Obviously, the pieces that we're talking about, whether it's best practices for providers or it's best practices around youth engagement and school and community engagement, those are the pieces. And the way that we have depicted this picture for you, just to give you an idea of why the circles and why the Q's and why the star, okay? So obviously, we believe that there needs to be quality practices in each of those areas. You have to have a focus in some way to really sort of measure the quality of your partnerships and know, are they really designed in a way to help get to where you want to get, and the same around finance and the same around practice, with the whole center always being a focus on the kids. So that we believe if you have all of those things in place, obviously if we have these three circles in place and we have those practices and all of these pieces in place, the outcome is going to be just great quality services for kids. All right. So I'm going to talk a little bit about partnerships first. And I love this slide because it actually depicts for us, I think, all of the folks that we have around the table, and it has to be many hands on this project and on the field of school-based health centers. What we've learned, what I learned early on when I came on to this job is that there was no way that the Department of Health could ever do this by itself. And I think most state agencies and most communities realize that even relying on state agencies anymore for your key source or your key activities alone is just, it's a recipe for disaster. I mean, I really, in terms of shrinking budgets and the way things are moving, it's just, even for me as a state office, I need to have those other partners to really sort of think outside of what's going on in state government and how we can move it forward. So in New Mexico, I'm going to lay a little bit of context just so that for the folks, some of you might have heard me already say this yesterday, but this is the map of New Mexico, and all of those shaded areas, each of those colored areas is what we call a public health region in our state. So it's broken up in quadrants, with a centerpiece actually being here in this county. Albuquerque and this Bernalillo County area is kind of like, it's where we have, it's our urban center, and this is where we have the majority of our folks. So it's actually separated out as a separate public health region because we simply have the largest number of people. And I just want to point out that for even as a school district, it's the largest school district in our state. So we have about 90,000 students that just go through school here in the Albuquerque public system. So that's really important. And as you note on this map, there's a large concentration of school-based health centers looking up at the northern part of the state. I don't know why. It's just started out that way. I think when we did our expansion 5 years ago, we had a concentration in the north part of our state. What we have found in our state is that it was actually where we probably had the most will in terms of acceptance for school-based health care, and we didn't really have to work and get around some of like the controversy that we all have to face around starting a school-based health center or running it. So that made it a lot easier for us as a state. So we started up there, and you will see that we have several up there. So there are 58 school-based health centers that are funded through our office, through the Department of Health. There's a number that floats around in New Mexico between 79 to 81 school-based health centers statewide. The other school-based health centers that are operating some are actually connected through Indian Health Service and the schools that they work with in BIE schools or Bureau of Indian Ed schools. We also have some that are just community-based types of organizations where they've popped up and they've started those. And then there's also some that are running through our community colleges and colleges. We're also the home of the United World College that sits in Las Vegas, New Mexico, and they have a school-based health center there. And they serve a high school age population, so they have to have some sort of care on campus to do that, but they also do a wide range of activities aside from just providing like health care. They also do a lot of health promotion and health education through there as well. There's a concentration of our school-based health centers in rural and frontier areas of the state as well. So, I mean, these little places up there, I mean, there's some really small ones. We've got a representative here from one of our very rural areas, or frontier areas. It's called San Juan, a very small community. And so we have a lot of these municipal schools that serve like a K-12 population. And some of them have, a student population of only like 150 students, to our largest school-based health centers probably have students of upwards of about 2,000 or 2,500 in some of our largest high schools. Our lightest concentration, obviously, is in the southeast. I'm not even going to go there. I don't want to even talk about why. But we're trying to get into that part of the state, but it's definitely, it's probably our most conservative part of the state. And so there's still a lot of controversy. There seems to be a lot of concerns around the whole issue of, especially around reproductive health and confidential services. We have our supporting partners help to implement some real key activities. So we're really pretty well organized out of our office and in our state. We currently have a partnership with Colorado, and we've learned so much about how organized we actually are. We're like, wow, that's pretty nice. So we have a set of operating standards and benchmarks that run through our office, and all of our school-based health centers are required to meet a certain standard. And those standards were actually developed in partnership with Medicaid and through the Office of School and Adolescent Health and Department of Health. And what's nice about that, it's sort of our credentialing standard also for Medicaid. So we use it for licensing purposes. So our school-based health centers that are sponsored through our office are actually required to implement those standards and benchmarks. So we have a credentialing and a quality assurance partnership with Medicaid. And we have ongoing quality improvement through the University of New Mexico. And let me see, am I supposed to be on the next slide? I think I am. Let's go here. Well, yes, I'll just do this. So this kind of tells you a little bit about our implementation partners that we have. And this is, as we were talking about sustainability, the whole key around partnerships is who broadly is helping you with your school-based health center pieces. It's not just about a compliance piece, or it's not just about a contract monitoring piece for us. We're also looking at ways to sort of make our school-based health centers very robust and very competitive in the healthcare system. So obviously we rely on our partnership with schools and communities. I mean, that goes without saying. We actually at the top of the list, because if you don't have your schools and communities even on your side and with you in this, there's not a whole lot you can do. So we really work very heavily with school health advisory committees that through the public ed department. One of the things that was really nice is our school wellness policy actually required our school districts to organize SHACs, or school health advisory committees. So those committees become really integral pieces and partners for us at the local level to implement our work. Now, with our Medicaid credentialing and our quality assurance, we have a relationship with the New Mexico Human Services Department, which is our Medicaid department, and they actually have a school health office. So through that school health office, they help us with the credentialing pieces for school-based health centers, but they also support the Medicaid and schools piece that helps to pay for those auxiliary services that school nurses are doing around occupational therapy, speech therapy, and so on and so forth. I can't underscore the significance of that relationship for us, and the fact that the Medicaid office has created an office and a niche, if you will, for school health, because they understand that there's some real significant nuances about how you want to do school health and how you want to organize that. And so we're really fortunate to have, a specific office in Medicaid that then becomes our arm to that whole entire system, because just Medicaid alone can be extremely daunting. Then we have a partnership with the University of New Mexico with Envision to do all of our quality improvement. This, it was like, when we first started this about 5 years ago, I was like, oh, I don't know, and, quality improvement, okay, they're so busy, they're having to do all this other stuff. And it really didn't click for me until this year. And when it clicked for us, they always say that it takes about 5 years to actually implement change and to really sort of adopt change. For us, this is when our aha moment came this year. We are in partnership with Colorado on that CMS grant, where we're the only 2 states out of all that money that was given out to states that actually has a focus on school-based health centers. And at the cornerstone of that is a quality improvement project. It's amazing, just the feedback that we're getting from CMS and the feedback that we're getting just from other partners involved with CMS around quality improvement. They're like, wow, you guys really have implemented a lot of work in this, and that's amazing what you've done. And what it also did for me is, in a recent meeting with some of our partners, one of our providers said, I am so grateful that you do that. I'm so grateful that you do quality improvement, that you have it set up for us this way, because if you didn't do it, we just wouldn't do it. We would just go about our merry way, and we would do it. It would be kind of like piecemeal, but it wouldn't be as intensive, and it wouldn't be as meaningful. And that's when I really, got the aha moment. Now, if you ask our coordinators whether they really like it or not, it can be a little intense for them. But for our providers, it's definitely making a difference in the quality of their practice. Our next partner that I want to talk about is our alliance, the New Mexico Alliance for School-Based Healthcare. And what we've done here is we have organized them around ongoing technical assistance and training. So they're our hub for those real nuts and bolts pieces around school-based health centers. This year we went through a restructuring in New Mexico because we were trying to align everyone to make sure we weren't blurring the lines between HIPAA and FERPA. And they've been a real integral partner in helping us to sort of move that through, getting sites credentialed, making sure that they understand the PE-MOSA process, and then just making technical assistance for us that actually help us coordinate our annual conference that we put together, and actually helped us with coordinating, getting folks here to this national convention. So those are the kinds of things that we rely on the Alliance for. They also do our online web directory. They've got online tools and resources for our school-based health centers, and we really encourage, our membership is actually pretty high as a result of that, because it's my central place for information. So I tell all of our school-based health centers, if you need information on school-based health centers, you don't contact us. You actually go through the Alliance and you look for it, because that's where we're going to post all of our resources. They post resources about grant opportunities. They'll even provide technical assistance around those pieces. And then finally, our data collection and evaluation is with Apex Education, a different organization that we work with that has become our data manager. So we have a data warehousing process where we make available a patient management system for those sites that don't have one. Our FQHCs obviously have their own, but we've made a patient management system available called Welligent. It was set up specifically for us around our school-based health centers. It's a great product. Actually, Apex Education is one of our exhibitors here, so if you have any questions about that or want to see some of their products, I highly recommend you go visit with them. But then they do all our evaluation, they do our data analysis, they do the crunching, and that was like a dream come true, because when I first started on this job, we didn't have anything. So it's been amazing. And then we can also offer a third-party billing service for those that can't bill on their own. So they also assist with that. So our sponsoring partnerships, and I just want to go over this really quickly, is this kind of tells you how we're set up. We've got FQHC centers. They're sponsored 24 sites. We've got 15 that are sponsored by university programs. And our university programs are pretty broad. We've got pediatrics, obviously involved in some. We've got family and community medicine. We've got the Center for Health Promotion. And we also have psychiatry, which was a new partner this year. So and then we also have a College of Nursing out in the Roswell area. Our regional education cooperatives is a different organization. They're a cooperative for smaller school districts, and they become like a purchasing power for them. So the school districts can buy into this cooperative, and they can purchase services for them at at a rate that makes it more competitive and and they also provide infrastructure and support. So we have some RECs that have come on board. We've got 9. We used to have just 1, but with our restructure, we added some more. Then we have some hospital-affiliated sites and other community-based organizations. What I want to just underscore before it's time for me to shut up is in the world of sustainability, as we look at this, the thing that's really nice about it for us is that we really have diversified. And in the diversification of this, it's really it's key. Obviously, FQHCs come with some different kinds of bells and whistles than maybe a university or an REC. But what's really nice is that there's some complementary pieces that each of these organizations can offer. So what we're learning from this is that the REC's relationships with school districts is amazing. And that is something that we need to learn more from, that could possibly, and we know not just possibly, but that will influence maybe information to our FQHCs. And then our universities, in terms of being teaching hospitals, again, also how their partnerships internally with university systems can also impact maybe other university systems that are not necessarily connected with some of our school-based health centers, but how we could get them connected. So I'm really excited about this because it really shows that we're not just relying on one particular system. We're trying to leverage as many points as possible around our sustainability piece, and we're, no stone unturned. I mean, that everybody knows that that's kind of like, I just sort of go, well, let's just figure out, let's find out, and we could find another partner, we could do this differently, so I'm really proud of the fact that we have diversified that, and I think that it's one of the key lessons that we've learned in our state about moving towards sustainability and the importance of our partnerships. And, I forgot, you guys have a handout. Thank you.
So they have homework.
So now you have homework. Okay. All right. So everyone should have a handout. And what we're going to do is, because you've got quite some time with us, and we didn't want to make this that, we're just going to be like talking heads up here. Oh, my God. And everybody, just wait till you hear Carol, because it'll be really fun. I wish I can't be as fun as Carol, but Carol's definitely fun. So Carol put together for us this little matrix, and what we want you to do is we really wanted this to be an opportunity for you to think about just the presentation that I've made just right on this part, just on partnerships. And, just kind of like sit down and sort of think to yourselves, if you will, around what are some of your ideas for partnerships that you've just heard as a result of this presentation, or how it's linked up to sustainability. And we're going to go ahead, Carol.
And does everybody have the handout? Or raise your hand if you don't, Laura's.
No, we ran out.
Oh.
I made 50 of them.
If there's extras. So we did want to make this a little interactive, because we know that as adults, the way we learn is we hear something and then we may have an idea that we want to apply when we go back home. So if people could turn to the person next to you, introduce yourself, and based on what you learned from Yolanda about partnerships, talk a little bit about maybe some new idea that you may want to implement when you go back home. Jot it down, and then in about 5 minutes we want to hear and get some of the ideas that were generated in the room. Okay? So some of you may need to move since we're spread out. Thank you.
Okay. We have 5 minutes plus.
Sure. Okay. Well, I said 5.
I know, but we're at 25 minutes.
No, I think it's
Well, we're at 25 minutes now. and each of us sit for 25.
Okay.
Without
So
sharing.
what we'll do, we won't give them 5.
Yeah, we'll just do
Yeah.
Okay.
And I think this was perfect. We did this because
Yeah.
this brings it up. It makes me less nervous when I
Me
have
too.
people talking.
Yeah.
Nice job. I mean, I'm proud of us in New Mexico. The landscape is great.
Nice. That was,
Yeah.
look,
I looked at the Oh, yeah. And I made it some notes because I can link back to you. And then I think you should wrap it up by just a minute or two. Just how about a 1 or 2 inspiring shares? And you'll be great, as always. It occurred to me I should have told Chris, gosh, if you want to see me, you know, I'm my mom or my sister. I didn't tell anybody, did you?
it was happening, but not how to get to it.
Yeah. Okay.
We'll be fine.
Tell them about 30 more seconds. Then
Okay.
partner.
All right. Let's kind of get ourselves centered and back to the room. I'll start cracking jokes, maybe. Except I'll have to have Carol come up and do that. Okay. I love the energy, but let's get back. Okay. So to be nice to our partners who are actually watching us on a video somewhere and listening to all the chatter in this room, this is great because it sort of gives me an indication that hopefully that the presentation sort of sparked a few ideas. Who would be willing to share maybe what they thought about this? And you have to come up to the mic if that's the only thing. You can't shout it out from your chair. You have to be willing to get up and come up to the mic. But, is there anything that sparked some ideas or interest for some folks? And you don't have to. If we're not going to, if nobody feels like they want to do that, that's okay.
A new insight?
We just, no new insights?
It was a little less than.
Yeah, we didn't quite go that whole time because we were looking at our clock and we were going, wow, we can't. We went a little over on that first part. I thought I was going to. I kept telling, I told Carol and Patsy too, I'm going to be the shortest part, and it didn't work out that way. So I think, just again, the whole purpose of us just really laying out and really being specific about partnerships is to really talk and just to really help you think about the importance of diversification there as well. As looking at how all of those pieces and where are they that really make up that partnership around school-based health center. It's not just about our healthcare providers, and it's not just about that industry, and it's not just about our schools. Those are the places we are. But we also need to think really broadly about who are the other players that can be pieces of this. Yesterday we did a presentation on a poster presentation that we're putting out. Key partnership for us was a managed care organization because we're not having to pay for it. So, we were able to do that whole youth engagement piece, get the feedback, but through the partnerships that we have, because we have a real strong alliance with Medicaid and with our Medicaid managed care organizations, they also stepped up to the plate and recognized a need and are going to help us with that campaign. So I'm going to pass it on over now to Patsy.
Great. Thank you, Yolanda. Well, where is the money? That's the next piece of this, is finance. And our partners team, our school-based health center partners team, and the Elevate team, and I don't know if any of you know about Elevate. This was a project that was in several states around the nation sponsored by the Atlantic Philanthropies. But at any rate, we had two groups that were actually working on sustainability. We felt like sustainability was something we needed to develop work groups around, and so we did that. And when we realized that we had two groups, we brought them together as one. So now we have one sustainability work group that's been working together for about 2 years to try to identify what are the key strategies that we can work on so that we can keep our doors open, which of course is what we keep thinking about. Understanding that we will never be able to rely on public money alone, and public money is being decreased all the time. The reason we call it Sustainability Plus is as we did our research, we also learned that our school-based health centers likely will never be sustained by billing alone. So what do we need to do? And when Yolanda talks about diversity, we need to think about diversity of funding as well. And so we'll kind of end my presentation with a little information more about that. But that's why we call it Sustainability Plus. So we have to figure out our productivity, which really is our revenue and our expenses, our payer mix, and our billing and financing. And those are the three categories that we have worked on within the finance area, and we actually put together a little sustainability guide. It kept growing and growing and growing with all the ideas. And in fact, I have talked with a number of you in the room. We got ideas from other states that we have put into this guide, and it's available on our Alliance website right now. So any of the products that we have developed through this process are available there. We did develop a modeling tool so that you could figure out how to put your expenses in, how to put your expected revenues in, where's the gap, and how can you make some adjustments. Key, however, to having the Sustainability Plus are some assumptions. And one of those assumptions is that you have stable sponsorship for your school-based health center. Whether it would be a federally qualified health center, an Indian Health Service, all the partners that Yolanda talked about. Now we know that federally qualified health centers get an increased rate when they bill. So that's where we try to go first, is to federally qualified health centers to get them to sponsor, because when they code properly and bill properly, they get a higher reimbursement, which, oh, by the way, we hope goes back to the school-based health center, not just into the big pot. Indian Health Service, same issue. In fact, the Office of Management and Budget, OMB rate, is even higher than the FQHC rate. And so that's another area where, we really encourage Indian Health Services to sponsor. Again, getting the money back into the school-based health center is an issue, so that little detail has to be worked out. The ability to bill Medicaid. Yolanda talked about the Medicaid credentialing. I think in some states it's called recognition, where the sites are recognized, and the ability to bill Medicaid and other insurances is critical. Medicaid credentialing here in this state, the site has to be credentialed, and so do the providers, and the providers have to be credentialed for that particular site. And what we have learned is that that's been pretty confusing. And yeah, here's someone in the front who's nodding. Yes, this is true. And they have to be credentialed with the managed care organizations in New Mexico in order to be able to bill. So, that's a pretty complex system. And part of what we're doing as the New Mexico Alliance for School-Based Healthcare is to figure out an algorithm, if you will, and a checklist. What do you need to do for whom and when? And so we're going to be putting that all together. We were moving along merrily with some of our other products and tools and realizing, whoa, we've got to have the basics handled first. So that's the work that we're doing right now. And then working with our managed care organizations as well for how they can have a single point of contact so that when our school-based health centers need to talk to them, they know how they can have one email address that will go to either of the four, any of the four school managed care organizations, and we're working really hard with them also to think about having one or two contacts, specific people who really learn school-based health care and understand what the issues are, come visit. You know, a field trip is really worth a lot to see what is it we're dealing with here, and then understand the contracting process. With the change that Yolanda talked about, taking some of the contracts, taking all of the contracts actually in New Mexico away from school districts and putting them with other entities, all those changes have now required re-credentialing for some of our sites, 16 of them as a matter of fact. So it's been, something again, you don't know what you don't know, and as you dig into these things, oh, whoops, here's this little mountain to climb. But the partnership has helped us address the questions, and the managed care organizations sit with us at the table. We're very, very fortunate in New Mexico that everybody's on board and realizes the value of school-based health care. And then the other thing is the staff, having a stable staff of coordinators, providers, and coding and billing clerks who really get coding and billing. In schools, people were hired who may not have ever worked in a healthcare system before. And so that's been a really important one. And again, our change in New Mexico of sponsorship this year caused some folks to lose their jobs and other people to be hired, or for them to be hired into a different system. And so that has been a little bit of a challenge for us. So in our modeling tool that we developed, and this is an Excel spreadsheet, it is not a big old fancy Access thing that frankly I'm too old to know how to do, but I can fill this thing out. So if I can do it, you can do it. It gives an opportunity to put in what are your costs. And we based our modeling tool, we tested our modeling tool with 5 or 6 school-based health centers and even tried to get some out of state to fill it out for us as well. So we could really pilot it. Does it work? Is it simple enough to fill out? Do people understand what they're doing? And look at the staffing. We based it on 38 weeks of being open. We based it on 5 days a week, providing both physical and mental health services. We did not include oral health services when we did this at the time. And, some sort of standardized pieces to, and had people fill it out. And believe it or not, they came within about $30,000 of one another in terms of the costs. So for all of them, given this kind of staffing, so you have a nurse practitioner or PA, a medical assistant or office assistant in the front desk, a coordinator, and some sort of a behavioral health therapist. And of course, these people are independent practitioners here in New Mexico, so the nurse practitioners and the behavioral health therapists can practice independently. What we came out with staffing was about $180,000. And then other operating costs, and you can see those there, were about $120,000. So roughly around $300,000 was the total cost. When we looked at potential for revenue, it was about $150,000. What does this mean? We're at $150,000 shy, which means we then have to have some way of getting that fund. And if you would come to the microphone if you have a question, that would be great. We're being live streamed, so you'll need to come to the microphone for a question.
You have to ask your own person. Sorry. I'm just curious about physician oversight and why there is no line item for physician oversight for your staffing. And then is this based on full-time for everyone or just part-time?
Well, it's based on being open 38 weeks. And so that would be the cost to provide those providers for 38 weeks.
5 days
If they, beg your pardon, 5 days a week, right. If they work for a federally qualified health center, they may go do something else during the time that they're not off. And then physician oversight was not built into that because it isn't required for a certified nurse practitioner. Now for a PA it would be, so there might be some differences in cost there. And for a mental health therapist, there is no physician oversight required. I'm not going to get into it, but we do have telemedicine in this state, which has been tremendously helpful. And our school-based health centers have taken advantage of getting consultation from physicians, psychiatrists, that sort of thing, through our telehealth, but we don't have time to go into that here. So does that answer your question? Yeah. Okay, great. Okay, so the other thing that we talked about were some revenue drivers in terms of, so if you have to make adjustments first before trying to run out and find more money, where do you make your adjustments? So we figured that you have to have a service population of at least 1,000. Now, if you don't have that many in your own school, you got to figure out how do you get a service population of about 1,000. Saturation rate or penetration rate is what it's called in some places. So what percentage of that service population are you actually having enrolled and have the potential to serve or are serving? So 50% for medical and 15% or more for behavioral health. Weeks and hours of operation, again, that's a place where you could reduce, and some of our centers have, if you need to right size or to think about keeping them open during the summer if you have a way to get kids there. Visits per user. Now, in New Mexico, when we completed this, we figured we needed about 12 to 15 visits and for medical and 6 to 8 for behavioral health. I went to a meeting with NASBHC recently with some other states who said, well, 12 to 15 is pretty high for medical. But that's what we came out with. And we realized that some of these kids are going to take half an hour, 45 minutes. But there are others that you can do a follow-up visit relatively shortly in. And if you are open 7 to 8 hours a day, so you have some before and after school hours, it's possible. Having run one of these, it was possible for us to get 12 to 15 in a day. It stretches you. You have to be really well organized. And, oh, by the way, the teachers have to let the kids out of class, which is one of the issues. But we really feel like there's good potential to be able to do that and to try to reach that benchmark. And benchmarks were one of the things that we set up in our sustainability guide. So, here's what you need to try to benchmark against. If you can't, then you need to make some changes. The other thing was payer mix. We really talked about making sure that the kids who are eligible and can be enrolled in Medicaid are enrolled, so that you then are collecting as much as you can if you have that contract, if you're credentialed and you have the contract with the managed care organization, you can do the billing. And then the other thing was reimbursement rate per visit, to be sure that you are coding and billing properly so that you get the best reimbursement rate for your visit. And we have a question. Yes, sir.
On your visits per user line, you said 12 to 15 visits. Is that per user
No.
per year or per encounter per day?
I apologize. I realized when I was looking, it's not visits per user, it's visits per day. Per day. Thank you. So sorry. And thank you for pointing that out. In terms of the reimbursement rate, our range for medical was $45 to $120 per visit, and we felt like you needed to average out at about $100 per visit, again, to be able to collect at least that $150,000. And then for behavioral health, it was $35 to $100, and try to average out at about $80 a visit. So that's the modeling tool that we have available to take a look at if you're interested in doing that. And the website is www.nmasbhc.org. So it's like NASBHC, but you put an M in there. New Mexico Alliance for School-Based Health.
And we've got it.
And we've got it,
Yeah.
right. Okay. Oh, gotta do our little revenue drivers. Okay, so productivity strategies that we wanted to emphasize are integration with the school, and this is so incredibly critical. I mentioned a little bit earlier, if the teachers won't let the students out of class to come to the visit so that you can provide the service, which is our main focus, providing the service. It isn't so you can bill. But, if we're to keep our doors open, we've got to also generate some revenue. So please don't think that I'm all about the money, because I'm really not. In fact, when I was running school-based health centers, we didn't bill a thing. We didn't have the ability to do it. We just provided the service. So that's where my heart is. My head now knows that we can't keep them open if we don't bill. But integration in terms with those schools, developing those partnerships in the planning and the sustainability process is critical. Then changing the drivers, and we'll talk about that a little bit more in a few minutes. Data collection is really, really important. Having the information about what insurance the student is covered by, or if there is no insurance, understanding that that is one of those other sustainability plus issues. We serve a lot of kids in New Mexico. Immigration's a big old issue here. And we serve a lot of kids who will not be insurable. And so we do not turn away any child who comes to our doors. And we have to recognize that we are there to keep the service provided to all children. And that's part of the sustainability plus as well. But we need to know that information. And if they're eligible, get them enrolled. To manage care, to manage the practice so that we provide that good quality of care. We have now a patient registry built into our Welligent patient management system so that we can track based on HEDIS measures, and we can, in fact, provide those HEDIS measures back to the managed care organizations. They love us for doing that. They want to stay as our partners because we do that. So in a presentation yesterday, the CVS presentation about return on investment, they said, data is our lifeline. I'm here to say yes, data is our lifeline. We really have to have that. We can also track our health improvement indicators. Are we following Bright Futures for the number of EPSDTs that we are providing? Are we, in fact, seeing kids back for their asthma and chronic care conditions, diabetes, etc.? So we need to remember about our data collection and have a good system in place and use it well and help our poor medical assistants and office assistants who are just running crazy understand the value of entering those data, of trying to get that insurance information. I see Bill here in the front nodding his head from Oregon. They've done lots of work around this. And in fact, we understand that Vermont has now figured out a way to find out insurance information on all kids in the schools, and we're going to be talking to Vermont next week. Clinic infrastructure, you need to have the number of rooms and the amount of equipment so that you have the ability to move your provider from room to room, not just have one room per provider. And that way you can see more kids more efficiently as long as you can operate like a regular clinic does, where they are able to set up a student in a room and then move on. Okay, thank you. I'm going to need to move on a little bit more quickly, so we've got to talk about our little billing and financing part here. I already mentioned establishing and maintaining the contracts with the agencies. We have approached the thought of commercial insurance and have found that that's more difficult, especially when you have a clinic that only has one office assistant, medical assistant. And for them to understand the variety of coverage that comes in on each child covered by commercial insurance just isn't possible right now unless you have a backup system through a federally qualified health center or something like that, or a university. So we're putting that on the back burner for right now for many of our school-based health centers until we get our basics of Medicaid covered. Maximizing reimbursement through proper coding we've talked about already, and I don't think I need to say more. And in fact, Joy and Teresa are going to come on after us and talk to you in depth about that. Maximize the provision of EPSDT, or the well-child visit. Not only is the reimbursement higher, it is a better way of tracking your patient care, making sure that you have determined through a health risk assessment what are the needs, and providing the counseling that the youth need. Developing a business plan. This is critical. We also have a template for a business plan that's available to you, and it really will help you tell your story. It will also collect all of the information for you in one document so that you can then write grants, because it provides the history, it provides all the financial information, it really shows funders that you have done your homework. All right, so if you don't have some of those benchmarks being met, then you need to move your revenue drivers. So, do you have 1,000 population? If not, do you expand your service to your staff, to their families, to the parents and the siblings of the children in the school? Know the number you need and then try to meet that need. Reach out. The saturation rate, who uses the school-based health center and who doesn't. What services are being accessed? In fact, our managed care organizations now are beginning to provide us back the information by school-based health center about what codes they are being billed for, so that we can cross-check and find out what services are kids coming in for and how do we expand the services that we're providing. The operation hours, when do the visits occur? Do we need to make any adjustments there? Patient satisfaction, critical. Why do kids come and why do they not come? Do a secret shopper thing, get some comment cards. We have a patient satisfaction survey in New Mexico that we're using now, and it has been incredibly helpful to have that information. Does the school support your efforts? Did they in the past? Do they continue? Will they refer? Are you losing patients because all of a sudden somebody in the school doesn't understand the value? Visits per user, being sure you do your follow-up appointments. I mentioned the patient tracking registry before. We talked about the payer mix, and then again the coding will be a different discussion. Staffing, do you need to change the staffing in any way? Are you hiring a physician when you could hire a nurse practitioner or a PA? Is there another way to get that physician oversight? What are your exact FTE and what shared responsibility can be there? We know that the team approach is one of the quality improvement concepts in the Affordable Care Act, and we know that that works in school-based health centers. And can school staff be a part of who helps and be a part of the team? Alignment with the infrastructure of the FQHC, or what needs to be bought and built. Does your school district provide you the space, the telephone, the internet connection, that sort of thing? So what are the drivers there that need to be changed? And I will conclude by saying you need to recognize the need for support and justify it. One of the last little tools that we developed recently was a fee schedule tool. How do you determine what your real costs are and develop your fee schedule based on that? Many of our school-based health centers either didn't have a fee schedule or had a fee schedule that was based on what Medicaid would pay, not on what their costs were, just like the rest of the healthcare industry does. And we also had some information from one of the finance guys at a federally qualified health center that if our school-based health centers would develop a fee schedule based on costs, they might get higher reimbursement from the commercial insurance companies. Yesterday, I think I heard that often it's lower. But if your fee schedule shows the costs, there's the potential for higher reimbursement. And then we have to realize that we need to somehow figure out how do we calculate the value of uncompensated care. You know, what's the value of providing care, confidential services for adolescents? What's the value of reducing teen pregnancy, reducing suicide, which is huge in our state, especially among our Native American population? So if we can use the return on investment when I went to that session yesterday, I was so excited. They are able to monitorize some of those issues. If we can add that in now as our next piece, I think we're going to be golden in terms of being able to show the real value of school-based health centers to keep our kids safe. And with that, I don't know that we have time. You do have on your handout an opportunity to think about what are the expense drivers and the revenue drivers, and think about what changes you think you might make when you get back to your home school-based health centers. And if you want to think about that a little bit, if we have time at the end. Do we have a few minutes?
Yeah. I think
okay. Well, why don't you think about that right now with your partner or somebody else you'd like to talk to, and just see if you can think or share some ideas for how you might change some of those revenue and expense drivers. And we'll give it about 2 minutes if you want to do that. Okay, thanks.
It's a lot. Yeah, it's a lot. You know, there are so many gems that I even forgot in there. The fee schedule. Oh, so many good things came out of it. Yeah.
Oh, I have one more.
They just adopt the Medicaid.
Oh, they don't
You
know
had-
what it costs them.
Yeah. I think it would be great if we could get one person to just share a gem. Just say, can somebody step to the mic and just share it? Use that language we have or insight. And I think I do need you guys to kind of give me the like, let me know when I have 5 minutes since I'm supposed to wrap it up, right?
Yeah, we've only got
26, so we got.
we gotta go.
And I may not have do this. At this
If you can begin to wrap it up, that would probably be good. Again, out of respect for our poor folks on the on the TV, although they are on their computers, they may be thinking about this too.
Might have got a break to answer.
Is there anyone who would be willing to come to the mic and share an aha about expense or revenue drivers? Or anything else that was an aha for you? No volunteers? Okay. Well, I'd just like to wrap up by my little piece by saying we know that we don't give free care. There is a cost to the care. We give it freely because we want our kids to have it, but we don't give free care, and I think it's important for us to sort of keep that in mind. The Colorado Health Foundation has suggested the diversity of funding that they actually require or are trying to require for the school-based health centers that they fund. And I thought it was very interesting to learn this. Their expectation is that 40% will come from patient revenue or billing, 27% in kind from the sponsoring agency, whoever that may be. So that might be your physician oversight. 13% from federal funds, and 11% from a state grant or a contract. Very different than here in New Mexico, where some of them have more than 50% or even 75% from the state, and 7% from foundations. So it's just worth thinking about that kind of breakdown of diversity as we move forward. Thank you.
Great. Thank you, Patsy. You know, if we had the opportunity to change the title of our presentation, I think it would be what we've got up there on the screen. And school-based health centers add value to the healthcare delivery system, because that's the underpinning of our whole presentation. While we're talking about expense drivers, revenue drivers, and partnerships in our earlier visual with the 3 circles, what really this is about is having school-based health centers viewed as from others as a very integral part of healthcare delivery. So the last part of our presentation is to talk about some of those strategies, tools that can be used to help move school-based health centers in that direction. The 4 things I'm going to talk about and put the most emphasis on youth-centered medical home, but is that student registries, a tool that we have called Youth Engagement with Health Services, and a student health questionnaire, all ways to really position school-based health centers to have practices that others may recognize and see as valuable. So first of all, youth-centered medical home. How many of you out there are currently working to have your school-based health center recognized? Yay, okay. So we've adopted that language here in New Mexico, although it is the same thing as patient-centered medical home. It is the same thing as health home, which federally the language health home and Medicaid is using health home more than often than not. So I want to just give a little bit of background. For so many people and healthcare providers, when you talk about health home, they kind of go like, really? You know, we've been doing that all along, especially people in the primary care business, pediatricians, family practice, family practitioners. That was the basis of their practice to begin with. But what happened in 2007 is core groups like the American Academy of Pediatrics, the American Academy of Family Practitioners, and Osteopathic Association got together to identify principles. And those principles were about access, comprehensiveness, integration of services, and relationships, all those things that many of us and for many years have already been doing. And they said, you know, we've got to do this to really improve health outcomes. And it was then in more recent years when the American Medical Association adopted it. So in our country right now, the language of health home is probably the most common redesigned tool and strategy being talked about and used. And school-based health centers have got to be in the forefront of that movement. Health home is also about a new ways of organizing your practice, and it's also changing how are you organized internally. What does the teamwork look like? What are the roles people are providing to your students or your patients? And then what are the reimbursement changes because you've adopted a health home? And not all states are adopting reimbursed changes for medical home. I wish here in New Mexico we were there. We're not yet. Even if you become a certified medical home as a school-based health center, there wouldn't be reimbursement changes. But if you're part of a managed care organization and you've achieved accreditation or certification, there are some changes that are happening that way. I do want to say that the whole approach about changing health outcomes, there are many states, and maybe some of you in this room, you have been able to prove that medical home has made changes. I think Vermont was the one that really showed a decrease in ER utilization. And Oklahoma, some of the literature is really showing that they were able to decrease the costs on Medicaid. So that's where really the impact on health outcome is really critical. So what does it look like for youth-centered medical home? So the comprehensive care, and I'm really going to really apply this to a school-based health center. So we have student health questionnaires. Student health questionnaires, how many of you are using those in your school-based health centers? Okay. It's a great tool that for the rest of the healthcare delivery system may be unique. That is an asset, it's a value added that you're bringing to the healthcare delivery system. When Yolanda mentioned some of the best practices, one of our best practices is every student that comes in completes a student health questionnaire. We want to find out, what are your health risks? What are your health assets that you're bringing to the equation? So don't underestimate that when you do that, that is not a common practice in other parts of our health system. Comprehensive care also by using a registry. And so we're really putting our toe in the water to talk about registries. And I'm going to go into a little bit more depth on another slide, but that fits into the whole comprehensive care picture. Being patient-centered or student-centered, one of the things that we're really trying to do is what is the list of concerns a student may have? And that's fairly common across the healthcare delivery system, often called a problem list. But again, I think caring for students, we're looking at a very holistic approach to what's on a student's mind. We're Also implementing patient satisfaction surveys. I think Patsy mentioned that. We're really trying to find out, how is the delivery of our care working? How did it work for you? What do we need to adjust? Again, not all parts of the healthcare delivery system are measuring patient or student satisfaction. So coordinating care. The fact that most and many school-based health centers have both primary care or medical care and behavioral health is key. How many of you offer both of those services? Okay. Don't underestimate that. You are a gem compared to many of the other parts of our delivery system who are begging for behavioral health services. We all know in school-based health centers that many of our students, and we learn this by the questionnaire, the student health questionnaire that we implement, they have a lot of behavioral health issues. It may be depression, it may be anxiety. The fact that we're gathering that information, it's going on their health list of concerns, and that we have tools to gather that information is a key added benefit. And then I think the fact that we're sharing that information within our practice between the behavioral health provider and the health provider is key. Also in medical home, they want to make sure, are you providing accessible services? Well, number one of the big value added we have as school-based health centers is the fact we're on the school campus. We're right there. We all know the benefits of being so accessible. Many of us provide walk-in care or at least same-day appointments. And I think that we've got to open up our lens when we think about accessible care, because it may be a telephone consultation. So when it goes back to that driver of 12 to 15 visits a day, it may not look as we've classically thought, put them on the appointment book, see those students. It may be as simple as somebody needs a quick telephone consultation. How are you using some of your technology with email with students and also consulting with them there? So accessible services looks a little bit different than it may have in the past. And quality. Quality is a key cornerstone of becoming a medical home. So, as Yolanda mentioned, through our partnerships with the University of New Mexico and Vision with pediatrics, we have our school-based health centers really getting a lot of technical assistance on how do you measure quality, how do you use evidence-based guidelines for our well child checks, the EPSTAT. What are the evidence-based guidelines around sexually transmitted infection? And then how do you use a medical registry review to look at how you're doing with that? Most of our school-based health centers are pretty familiar with the Plan, Do, Study, Act small cycle of improvement. And we like to say, let's make that living, breathing. Let's make that a tool that you use on a routine basis to improve the quality of your care. So when you think about, wow, what value are school-based health centers adding to the bigger healthcare delivery system? If you've had quality measures, you're using evidence-based guidelines, you have some familiarity with the continuous quality improvement, and you know about using a PDSA tool, you may be one giant step ahead. So in an earlier conversation, we were talking about federally qualified health centers, and do they value if they're connected to a school-based health center? In one of our experiences, we had the FQHC say, wow, thank you for the quality improvement work you've done with the school-based health center. We've adopted some of those tools, and we're using them back with our other clinics. So don't underestimate, if you've got a strong quality improvement program, what value that's adding and how your staff is really familiar with those tools. Okay. So I think this is the $100 million question. There are a lot of ways to become a health home across the country. And the big thing is we want school-based health centers really trying them out to say, can we become certified? The common denominator, they all have an assessment tool. They all have standards and benchmarks. And there's also a certification attached to it. So I want to go back to partnerships and say when we began our journey, it was really through our new best friend, our managed care organizations. And we adopted the language, who's our new best friend? It's the MCOs. And that was kind of new for us. You know, in the past, we didn't even bill. They had requirements. But our MCO partner came to us and said, hey, will you take these standards, these medical home standards, and see how they apply to a school-based health center. So we did. They did the walk with us. They came to a weekly meeting, and what happened out of that is they learned about the value of a school-based health center. The dividends were endless. What grew out of that is, as I think one of my colleagues mentioned, here in New Mexico, we are one of the demonstration sites through CHIPRA, or the SHIP initiative with Colorado. And so now we've taken our early experience with our MCO partner, and we are assessing our school-based health centers and using the NCQA, or National Committee on Quality Assurance, to see if we can become NCQA certified. What we're learning about that is that the method you choose to become a health home really depends on what is your sponsoring agency or your administrative sponsor. What direction are they going? So in the beginning, when Yolanda showed the array of, we've got FQHCs, we've got universities, we've got the Indian Health Service, we've got regional educational cooperatives. Our first step on this SHIP or CHIPRA journey is to say, okay, let's go back to your administrative sponsor. Are they on this journey? We want to be in direct alignment with them. So I've got some of my partners here that are working with FQHCs, and we're very confident after our early assessment that we can meet a level 1 for NCQA pretty easily. Even without an electronic health record, you can pretty much get to a level 1. We're confident we're going to reach farther. Many of our FQHC partners are saying, hey, we're going for a level 2 with our other clinics. We're going for a level 3, and that's the level we're moving toward our school-based health center. I think two of the biggest concerns that have come up is about after-hours access. So as a school-based health center, you usually have a sign on the door, here's the hours. If you have an emergency, dial 911, or if you're connected to another clinic, you might have that number. Here in the state of New Mexico, we're very fortunate to have a 24-hour nurse advice line. So we wondered how can we use that asset to meet that school-based health requirement? So one of my favorite things to do is to send questions to NCQA and then have them send back or call them, because I say, we're on this journey. We want to be part of you. And so the early answer I got is the nurse advice line would meet that requirement. The other thing that how are we doing on time? 5 minutes, okay. Then I probably better keep moving. Lost my train of thought. Well, so the other tool that we'll be trying is the improving patient care. So one of our sites, Laguna Acoma School-Based Health Center, some of you went on the tour out there about an hour west here of Albuquerque. Their administrative sponsor, they're very connected to the University of New Mexico, who's using NCQA, but Indian Health Service has a wonderful improving patient care initiative. All of these initiatives for a health home really have the same kind of building blocks: comprehensive care, patient-centered, coordinated care. They just may have different packaging, but they all have those major tenets. So with Indian Health Service, it looks like for that clinic, we're going to be going with the Indian Health Service model. Why? Because that's who is sponsoring the electronic health record, even though they also have university connections. So it's one of the first steps is to know which direction you want to go.
I think Laura's going to.
Do you have a question, or are you telling me
I
I'm
just
out of
wanted,
time?
no, not a question. I just wanted to say that NASBHC on our website, we have a whole web page dedicated to the medical home. So all of these, except the Indian Health Service one, we need to get that up there, are up there in terms of downloading the tools and working with them, and also a listing of states and all the different state programs, just in case you weren't going to mention that.
Yeah, thank you. And that reminds me, Laura, too, I do want to encourage people to attend the NASBHC session G4, 9 a.m. tomorrow, because they're going to go into more depth about patient-centered medical home. All right. Oops, sorry, I keep going the wrong direction. I just want to say a couple things about student registries, because again, if our whole premise is let's make sure school-based health centers are an integrated part of the healthcare delivery system in our country, student registries are a common tool used, and it can help really improve practice and make sure that your students have received the preventive services, or even if you're managing chronic care conditions. My whole thing I want to say is it can be as simple as a list of students. Which students in our school haven't received their well child check this last year? We all know adolescents are one of the most underserved populations in our country. So that is a great starting point. It doesn't have to be fancy. It can be an Excel spreadsheet where the students listed when was the last time that they had their well child check. In our state, even we're reimbursed to receive 2 well child checks in a year. So we really monitor that. We think it's the basis. If you are a health home, you really want to do the EPSTAT and to make sure that you've got that information in there. So it can be, and the reason I have the arrow down the side, it's as simple as a list of students, or it can go as more complicated to having all the components for evidence-based practice on how you manage a sexually transmitted disease. Did they have the chlamydia screening? Well, when was the lab work done? Put the dates and the time of service and to manage that. But again, this goes back to another tool that school-based health centers can have to position themselves to be a part of the bigger system. And I guess we're moving to the end on just funding opportunities. And again, I think we all know we're waiting to see what the Supreme Court will decide. But I know, as NASBHC's been saying, and many folks, it really in many ways won't matter where healthcare reform lands, because we know things are going to change. And regardless, school-based health centers are going to be in the forefront, and we want them to be in the forefront. We know that money for operation in health reform was authorized, but it wasn't funded, and that we know that there's a lot of money out there for building centers, and that's a good thing. We talked about youth-centered medical home, and depending on your state, there may be enhanced reimbursement if you become a medical home. EHR, electronic health records, while many of us are going that route, it is part of health reform. And it is part of patient-centered medical home. If you're going some of those higher levels of certification, you will need to have an electronic health record. You know, the language of meaningful use, how are we using data? They're so aligned on the patient-centered medical home standards and what meaningful use data is required. They're very tied in. So I think those in many ways go hand in hand. We talked about patient registry, and then Patsy mentioned about commercial billing. So I'm going to close to say we do hope that you will go to our New Mexico Alliance website, and the web address is at the bottom of the page, or it's on your handout. And that's where our school-based health manual that we've worked on over the last few years is located. As Yolanda mentioned, she uses that site, so we make sure that from the state end, we have everything for school-based health centers right there. We are integrating the manual that set the standards that Yolanda mentioned, which is a real big achievement from our Department of Health, along with our sustainability guide. That's how we as partners are working together. It's electronic, it's by chapter, it's on our website, and then our Excel tool is on there, so you can model based on how many students do you have in your school, and look at that tool as well. So I think with that, we'll close by saying, really, never forget your mission. It's all about the students. We know that's why you're all here, and that's why we're here, and we thank you for coming to our presentation. And we might have time for a question or two if somebody would go to the microphone.
Thank you. It was an excellent presentation. I'm wondering that certainly in terms of reimbursement, I mean, we live in a fee-for-service world which is changing to some kinds of alternative payment methodologies which we don't really understand because they haven't been implemented very effectively anywhere. I mean, you know, some are talking about going back to the old, payment per child per month.
Yeah.
That may not work so well if you don't have all your kids in a medical home and you still do want to provide urgent care or provide some kind of care on the patient registry to reduce asthma incidence, for example. What work have you started doing around how to SBHCs can get reimbursed under various alternative payment methodologies?
Great.
Well, one of the things, we have Medicaid redesign going on in our state, as many states do, and we have submitted, it's called Centennial Care here in New Mexico, and our partnership looked at the concept paper for that, which did include school-based health centers, by the way. We were very pleased to see that. And we developed a set of guidelines that could be used for the potential for contracts with school-based health centers. So we had some of that information in there that we've submitted. It's open, available to anyone. We submitted it to the Human Services Department where the Medicaid agency resides. We've also given it to all the managed care organizations who will then be answering the RFP when it comes out, so that this is open information for everyone. We also have one of our managed care organizations who has set up a school-based health center policy, a provider planning council meeting that we're going to be having this Friday. And one of the things we'll be talking with them about is what would be the best way for financing to come through this Medicaid redesign to school-based health centers. So we're working with our partners, as you know, all of our partners on all sides, around how can school-based health centers best be sustained through exactly what you're talking about. Is it bundling payments, cobbling together some form of payment that will be more sustainable? So good question. Yes, ma'am.
Hi, I actually have two questions. One is the financing model that you have universal across all your sites in New Mexico?
Well, the answer is yes, anyone can use the model
Okay.
to see where they are and calculate where they need to make changes.
Do you
yes.
actually know how many are using that effectively?
Very few. Very few.
I think what's important to note about that is that when we did the modeling tool is that we did it with a variety. So it wasn't just like all like institutions. So it wasn't just all FQHCs. We actually had, we wanted to model it across some of the different sponsoring entities so that we could see how it would work.
Okay, and my second question is, can you talk a little bit about your CMS grant? Because I understand I totally know what the grants were about. We actually applied for one too, so congratulations. We didn't get ours, it's okay. But the idea that that's a back out, you have to show cost savings. So can you talk about how you demonstrate cost savings with whatever you did with your CMS grant? Thanks.
We did not get a CMS Innovation Grant. It's the CHIPRA, the Children's Health Insurance Program, grant through CMS that we got. So this was not the cost savings innovation grant. Okay. Does
So
that answer your
in
question?
terms of just the CHIPRA project itself, there's a lot of focus on quality improvement. So the focus for ours, we're demonstrating with a total of 10 sites in each state, and we're focusing on quality improvement in areas around obesity prevention, STI, well child, depression and anxiety. And then we're also implementing some new tools around the health literacy piece. So the survey that Carol mentioned is called YES, which not only helps us around the satisfaction of those services, but we're also sort of going to be able to gauge the youth's engagement with their health care. So what we're trying to say, or what our premise is that school-based health centers have they're positioned in a unique way to really improve the health literacy of young people and in the management of their care. So with the YES survey, which we're hoping is going to be something that will become a tool that will become available nationally, it's going to be the first time that school-based health center providers will be able to really obtain feedback about how well they did in that process of engaging youth in the delivery of their health care.
I wanted to add one other thing that I think I glossed over. When I talked about the student health questionnaire as well, and through the CHIPRA initiative, we've actually made that an electronic tool. And students do complete that on an iPad. takes about, 5 minutes, Colleen? And that's been the biggest hit. Between the YES survey that Yolanda's mentioning and our new electronic student health questionnaire where they just go bing, 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 we've reduced it from about 20 minutes to 5 minutes. Kids, technology, they love it. And what's really great about that, through partnership, many that Yolanda mentioned, with the with Yolanda's shop at the Department of Health, with Apex Education, you can also get a summary, a risk summary, based on that student health questionnaire, so the provider can see, color-coded, whoa, what do I need to be concerned about? What do I need to talk with this student about? So we're hoping that technology will spread also throughout our state and other places. That's been key. It's one of those key tools when you think about the value of school-based health center more broadly. It's a great thing. And I also wanted to add the question about how many folks have used our modeling tool, and we're hoping to provide more and more technical assistance, but this just shows how our partnership really is valuable. So when Yolanda does contracts with our department, through the Department of Health, with all our school-based health centers, she's requiring a business plan. And she's streamlined that over the years, but what's going to help inform that business plan are some of these tools. So those are the kinds of things that we talk about together as school-based health partners, to really be integrated and to support each other to make school-based health centers successful.
Yeah, we definitely have focused a lot of our business planning and operational planning with our sites to get to start thinking about that. What are your drivers? Like, what is your saturation rate? What's your market? What's your potential? Because we do know that we still have some underutilization of our school-based health centers, and so we're sort of sneaking it in there and pushing it in there. But that's one of the requirements coming out of our office, because it's one of the requirements I have to get back, to like the legislators and to state office in terms of around, what are the partnerships that are going on at the local level with those school-based health centers to make them more sustainable? And they're pushing us around sustainability because they're saying, the state isn't going to drive it all, and sort of looking at those modeling pieces of how much of a percentage do we have in the game.
We appreciate your interest. We'd be happy to take additional questions personally, but I know you need a break, and there's another session to start. So thank you so much again.